Welcome to week 5 of your IV therapy course. We're going to be going into some details regarding the initiation of IV therapy, particularly in terms of infection control. So please refer to your book. There is a great breadth of information, and just for brevity, please refer to your book. Otherwise, we could have a 6-hour PowerPoint lecture on the details here. IVs provide direct access to the vascular system. Therefore, understanding the epidemiology and the common causative organisms are imperative to implement standards of care to prevent infusion-related infections. This is critical when engaging in IV therapy practice. Because of the potential hazards and complications, there are multiple governmental organizations that set standards and guidelines in regards to infection control. Refer to page 53 in your textbook for the complete list of organizations responsible for establishing the standards and guidelines. Here is just a few of them: the CDC, OSHA, INS, CMS, and APIC. Also, the Joint Commission is very important. The CDC is a division of the Department of Health and Human Services and establishes guidelines for general infection control practices. OSHA is the enforcing agent and mandates protect employees. The INS sets standards for practice and makes policy and procedures. CMS has a goal to transform and modernize the healthcare system. And the Joint Commission establishes quality of standards and performance measurements, while APIC emphasizes prevention and promotion, zero tolerance for healthcare-associated infections. In order to understand infection prevention, it's crucial to understand immune system function. The immune organs and immune cells recognize the self from the non-self and protects against microorganisms and abnormal cells. Invaders, also known as antigens or foreign bodies, bombard the body and trigger the immune response. These can be viruses, bacteria, or parasites. Immune response corrects when it recognizes those non-self antigens and then will destroy them. There's also a cleanup crew that disposes of those used damaged cells. There's more information in your Phillips and Gorski book that provides a great overview of the many functions and the importance of the immune system. The organs of the immune system include the thymus and the bone marrow, lymph nodes, spleen, liver, Peyer's patches, tonsils, and adenoids. The thymus and the bone marrow are the primary organs. The rest are secondary organs, along with the appendix and lungs. There's more information in your book on page 54 in table 2.1. The immune system works in lines of defense. There's the first line of defense, or the innate defense, the second line of defense, or the nonspecific innate defense, and then tertiary defenses, or adaptive or specific immunity. We have leukocytes and we have lymphocytes that have adaptive immunity. Tertiary defenses, or the adaptive immunity, develops after exposure to an antigen. So then with repeated exposure to that same antigen, the immunity response becomes better because of the memory T cells. And a note about T cells, they're called T cells because they generate and mature from the thymus gland. And then when we talk about B cells generate and mature in the bone marrow. So T for thymus and B for bone marrow. There are two types of immunity: nonspecific and specific. Innate is also called nonspecific. Innate immunity is the first line of defense against the antigen. Innate immunity is present before exposure to an antigen and is not enhanced by successive exposures. Nonspecific, or natural immune response, is present at birth and function without prior exposure to the antigen. However, specific immunity is acquired and functions when prior exposure to antigens happens. Now let's go into detail about nonspecific immunity. There's great information in pages 54 and 55 about physical barriers. The first line of defense is the presence of mechanical and chemical barriers that limit entry of the microorganisms into the body. These include intact skin and mucous membranes, the presence of normal flora, secretions containing antibodies, hydrochloric acid in the stomach, and lysosomes in tears and other secretions. For example, the mucous membranes will trap the pathogens, then expel them. Chemicals, when we're talking about chemical barriers, inhibit the growth and the invasion of microbes, and acid secretion helps with that. And then when we're looking at the GI and urinary systems, they also contribute by expelling organisms from the internal environment. The second line of defense gets activated when the first line of defense fails. Its function is to limit growth of microorganisms in the body. These include natural killer cells, which kill cells infected with viruses, neutrophils, which are responsible for ingesting and destroying microbes, as well as macrophages that ingest and destroy microbes. The helper T cells help to activate the adaptive immunity in the presence of an antigen. Other secondary lines of defense include inflammation, in which histamine and other chemicals released from the damaged cells or from basophils respond. Phagocytosis, in which the white blood cells engulf and destroy those pathogens. And a fever, which allows a rise in core temperature, increases the metabolism to inhibit the multiplication of pathogens. And finally, the complement system, which is a set of blood proteins that trigger release of chemicals to attack invading cell membranes, causing rupture. This also signals the white blood cells, particularly basophils, to release the histamine, thus the inflammatory response. The third line of defense, or specific or adaptive immunity, or what could also be considered tertiary, is what we're going to talk about next. Tertiary defenses, or adaptive immunity, develops after exposure to an antigen. With repeated exposure to that same antigen, the immunity improves its response because of memory T cells. The adaptive immunity is mediated by antibodies that are produced by B lymphocytes and two types of T lymphocytes, the helper T cells and the cytotoxic T cells. And just a reminder that the B lymphocytes, the B stands for bone marrow, and with the T lymphocytes, the T stands for thymus. Passive acquired immunity is passage of immune cells from one person to another, or gamma globulin infusion, which some of our patients will have. Active acquired immunity is actual direct contact with the antigen. So when we're talking about adaptive immunity, we need to remember that leukocytes, T cells, and B cells, or T lymphocytes and B lymphocytes, immunoglobulin, and there is a complement cascade that happens in adaptive immunity. Lymphocytes provide specific antigens in recognizing because of what's called the HLA, human leukocyte antigen genes. This is like barcoding that we use in the stores. We use a barcoding to identify the different items. Well, the HLA, human leukocyte antigen genes, they do the same thing with antigens so that the body's quicker to adapt and to respond to an antigen that has been barcoded before or has been introduced to the body before. Remember that antigens are the foreign bodies that we come in contact with. When one of those enters our bodies, there are phagocytic cells that routinely circulate in our blood, and they will be summoned by chemical markers at the sites of infection or invasion of these antigens. And again, we use the HLA, the barcoding system, to identify what that antigen is so that the body can respond appropriately. Foreign antigens stimulate then antibody production, and we'll talk more about antibodies in the next slide. Antibodies are also known as immunoglobulins or gamma globulins and are abbreviated with a capital I lowercase g. They aid in the destruction and neutralize toxins. Immunoglobulins circulate through the body, interacting with and aiding in the destruction of any potentially harmful microorganism or toxin or antigen. The main function of these antibodies are to neutralize those toxins and invaders such as the viruses and bacteria, and then make them easier to phagocytize. Page 58 of Phillips and Gorski's Manual of IV Therapeutics provides a summary of the 5 different types of immunoglobulins. Another type of adaptive immunity is cell-mediated immunity. In this immunity, there is no antibody production. It does not involve antibodies. There are helper T cells which recognize foreign antigens. The memory T cells will then remember that specific foreign antigen. Then the cytotoxic or killer T cells chemically destroy the foreign cells. Then the suppressor T cells limit the immune response to what is necessary so that you don't have an exaggeration of symptoms. So when that happens, the helper T cells are out there helping recognize those foreign antigens. And when they recognize a foreign antigen, if we've never had that antigen before, the body builds the chemical destruction for those, then memory T cells are developed from that so that the next time we're exposed to that antigen, it will be easier to attack it and suppress it. The next type of immunity is humoral immunity. And with humoral immunity, it is the production of antibodies. Okay, so there will be recognition of the foreign antigen, which may be accomplished by macrophages and helper T cells, or even by B cells. Some B cells become plasma cells, which produce antibodies to a specific foreign antigen. Then memory B cells can initiate a rapid second response to the foreign antigen, or even more subsequent responses. And then suppressor T cells limit the antibody response to what is necessary. Antibodies bond to the matching antigen, which promotes phagocytosis or complement fixation. Keep in mind with antibody responses, there has to be a first exposure. So we have to be exposed to that antigen. So then the antibodies would be produced slowly and in small amounts. You will get sick. Illness may occur. But on a subsequent exposure, large amounts of antibodies are rapidly produced because the body remembers that. And it's often enough to prevent another case of the illness. So for example, when we have a vaccine, that would take the place of our first exposure so that the actual exposure to the antigen is like a second exposure and the body can respond. A good example of that is the varicella vaccine for chickenpox. So we know that that's a common childhood illness, and we've developed the vaccination for that. And so whether or not you have actually got the disease for chickenpox, or if you've gotten the vaccine, those are considered your first exposures. So that's why later you become what we call immune to chickenpox, because you've had that first exposure, you've developed the antibodies to the chickenpox. So then when you're faced with that antigen again and exposed to chickenpox again at the second exposure or even a third exposure, you don't develop the illness. So vaccines are a great example of that. Another great example of antibody response is allergies. In order to have an allergic reaction, you have to first be exposed to that antigen. And what happens is, through a series of missteps and things like that, the body hyper responds to those antigens, and then you develop an allergic response. So you'll have the inflammation, the itching, and all the histamine release that accompanies with that every time that you're exposed to that particular antigen. And anaphylaxis is a good example of that. And then with repeated exposure, the response becomes exaggerated. So that's kind of anaphylaxis, what happens. And then you have the respiratory issues and the vasovascular changes that happen, and all the respiratory issues that happen with that. There are different types of immunity, such as genetic immunity, where inherently you're immune to different diseases. For example, a good example of genetic immunity is people who are recessive, have just one gene of the sickle cell disease gene. They are immune to malaria. So that would be an example of genetic immunity. Acquired immunity is when you are exposed to that antigen and then develop the immunity. There is passive acquired immunity, which is the passage of immune cells from one person to another. A good example of that is a mother to a fetus or through breast milk. Okay. And then active acquired immunity requires direct contact with the antigen. Don't forget leukocytes, T cells, and B cells or lymphocytes, immunoglobulin and the complement cascade, as well as the HLA, human leukocyte antigen genes, the barcoding, are very important when we're talking about immunity. Now let's talk a little bit about epidemiology, which is the study of disease processes and exposures to those diseases. There is something called colonization, and that is when there is a microorganism in or on the host that grows and multiplies, but you have no signs or symptoms of infection or a detected immune response at this point. Dissemination is the shedding of the microorganisms into the immediate environment from the person carrying that microorganism. Only a fraction of colonized persons are disseminating. Cultures of air samples, surfaces, and objects reveal dissemination or shedding of microorganisms. Some facilities routinely culture all or selected asymptomatic staff in an attempt to identify carriers of certain organisms. For example, MRSA. However, such surveys lack practical relevance unless they are related to a specific outbreak of the disease. Then we have nosocomial infections, which are also known as hospital-acquired infections. Healthcare facilities, whether it's hospitals, nursing homes, or outpatient facilities, can be a dangerous place for the acquisition of infections. The most common type of nosocomial infections are surgical wound infections, respiratory infections, genitourinary infections, and gastrointestinal infections. These infections are often caused by breaches of infection control practices and procedures, unclean and non-sterile environmental surfaces, and/or ill employees. Infections are considered nosocomial if they first appear 48 hours or more after hospital admission or within 30 days after discharge. The four most common nosocomial infections, of which comprise approximately 80% of all nosocomial infections, are urinary tract infections, surgical site infections, pneumonia, and intravascular device-related bloodstream infections such as IV catheters. That's why it's imperative to understand immunity and epidemiology in light of IV therapy. In looking at breaking the chain of infection, we have a whole gamut of things that we are attempting to do to make it better in our healthcare facilities. There are new microbiologic methods, advancements in epidemiologic methods, continuous quality improvement in which dedicated staff look at documentation and assessment and interventions that we provide for our patients and the way that we follow up with them, risk management, antibiotic use, and pharmacoepidemiology, which is the study of the pharmaceuticals in direct relation to epidemiology, and then emporiatics, which is basically understanding travel and how that impacts infection control in our country. On pages 60 through 63 of your book, there is a great explanation for each part of the chain. The chain of infection includes causative agents, the reservoir, portal of exit from the reservoir, method of transmission, portal entry, and susceptible hosts. These are those 6 links for infection control. And to control infection, the chain of infection must be attacked at its weakest link. Now we're going to talk a little bit about infusion-related infections. So we're going to talk about the epidemiology, the pathogenesis, catheter-related infections, and sources of catheter-related infections. So just keep in mind that epidemiology varies with the type of catheter and the frequency of manipulation and other patient factors. In looking at epidemiology, there are greater than 5 million central venous devices inserted annually. And there are more than 250,000 nosocomial bloodstream infections each year. This is data that the CDC collected between 1972 and 2002. And so we know that it does take time to collect and assess that data. So when we get information from the CDC over a long-term period, it will be a little bit behind. But if you look at that, that's a huge amount of infections that could have been prevented. So the importance is not just looking at this data, but understanding what we're doing to eliminate those nosocomial infections. Now let's talk about pathogenesis. Important pathogenic determinants are the material of which the device is made and the intrinsic virulence factors of the infecting organism. And remember, early in the first couple of modules, we talked about the different materials that the IV catheters are made of, and there's different options. And over time, that has changed based on the attempt to decrease these catheter-related infections. So now, speaking of catheter-related infections, we know that there is a rate of 5.3 bloodstream infections per 1,000 catheters. 250,000 central venous catheter-associated BSIs occur each year. BSI stands for bloodstream infection. The mortality rate for each of those infections is anywhere from 12 to 25%, and that's huge, especially if we're talking about your loved one. The cost for each of those infections is $25,000 to $45,000, which is very expensive and taxing on the healthcare reimbursement arena. Infections are caused by skin normal flora. And what happens is there's a delayed infection that can occur 2 to 3 weeks after the catheter implantation related to poor wound care and migration of those organisms or those normal organisms on the skin. Refer to pages 66 and 67 in your book, but we'll talk about sources of catheter-related infections in this slide. It can be skin organisms, contamination of devices prior to insertion, contamination of the catheter hub, and contaminated infusates. Fluid can be contaminated, or the infusate can be contaminated through manipulation, microbes entering the bottles from entry points, compromised integrity of the container. There's more discussion about prevention on pages 68 through 71, so please refer to those pages. Now let's talk about strategies for prevention and treating infection. Nurses involved in maintaining vascular access devices must have the knowledge base and competency to implement evidence-based interventions to reduce infection risk. The principles of infection prevention provide the foundation for the delivery of the infusion therapy. Prevention begins with knowledge regarding the techniques used to prevent infection. And it's imperative with this IV therapy course that you highlight all the things that you're doing to prevent infection. We're going to talk about the infection control practices developed by the Center for Disease Control, or the CDC. And we're going to talk about standard precautions, Tier 1, Tier 2, and the combination of universal precautions and body substance isolation practices. Standard precautions are intended to be applied to the care of all patients in all healthcare settings, regardless of suspected or confirmed presence of infectious agents. The standard precautions are based on the principle that all blood, body fluids, secretions, and excretions, except sweat, non-intact skin, and mucous membranes may contain transmissible infectious agents. Standard precautions include the following infection prevention practices: hand hygiene, personal protective equipment, or PPE, such as gloves, gown, mask, and eye protection, which can include goggles or a face shield. Please keep in mind that the application of standard precautions is determined based on the type of interaction with the patient. For example, if you are starting an IV, only gloves would normally be worn. It is imposed if there is a risk of exposure to blood and other body fluids in contact with non-intact skin and mucous membranes. That's when we would use standard precautions. Tier 1 standard precautions includes hand washings, gloves, gowns, and other personal protective equipment. Hand washing, for testing purposes, you need to understand that 15 to 20 seconds of hand washing is important. We use soap and water. Chlorhexidine. We used to use betadine and alcohol prior to chlorhexidine. Remember, 15 to 20 seconds, and after touching or after removing gloves, it's imperative for hand washing. Also keep in mind that hand washing has to happen prior to eating and after toileting. Gloves need to be clean, and we need to change gloves between tasks. Also, we have to remove the gloves promptly after we use them. The purpose of mask, eye protection, and face shields is for eye protection, protection of our mucous membranes, and we need to use that if patient care activities are likely to generate splashes or sprays. We wear gowns to protect our skin and to prevent soiling of the clothing, and we're going to use this if the patient care activities are likely to generate splashes or spray. Other things to consider are patient care equipment, the environmental control, linens, occupational health and bloodborne pathogens, in particular the policies around that, and patient placement. Remember that each facility has their policies that should revolve around determining how to manage infection control practices, and that will always detail what to do with patient care equipment, the environment, your linens, if you are exposed to bloodborne pathogens, and patient placement. This slide provides a great deal of information of things that we commonly see in our healthcare facilities in terms of infection control. We talk about hand washing, gloving, sharps disposal, safe handling of soiled items and waste, and then appropriate cleaning. There are transmission-based precautions such as airborne contact as well as droplet, and each facility should have their own policies on how to handle that. Tier 2 standard precautions are airborne precautions, droplet precautions, and contact precautions. We'll go into detail in the next few slides. Airborne precautions require special air handling and ventilation to prevent the spread of organisms. Healthcare personnel caring for patients on this precaution are required to wear masks or respirators, either the HEPA mask or the N95, depending on disease recommendations and your facility's policies. The mask is donned before entering the room. For patient transport to another area of health facility, the mask must be worn by the patient. An example of this would be for tuberculosis. Droplet precautions require the use of mucous membranes protection to prevent infectious organisms from contacting the conjunctiva or mucous membranes of the nose or the mouth. Examples of droplet precautions are mumps, rubella, influenza, adenovirus, rhinovirus, and pertussis. Healthcare providers must wear masks and goggles or face shields when caring for patients on droplet precautions. Patient transporting outside the room, the patients should wear a mask if tolerated and follow respiratory hygiene and coughing etiquette. Contact precautions require the use of gown and gloves when direct skin-to-skin contact or contact with contaminated environment is anticipated. We don personal protective equipment, gown and gloves, when entering the room and discard it before exiting the room. Hand washing is a must. Patients in this type of precaution would have equipment assigned only for his or her use. Patient transporting outside of the room should wear the gown. An example of this would be Clostridium difficile, or affectionately known as C. diff. In summary, here are the strategies for infection prevention. Follow hand washing procedure. Know what is clean, disinfected, and sterile. Know what is dirty. Correct contamination immediately. And then follow our CDC standard precautions guidelines. In order to place peripheral intravenous catheters with the goal of providing positive vascular access outcomes, you must understand the anatomy and physiology of the skin and venous system and be familiar with the physiological responses of veins to heat, cold, and stress. It is also important that you become familiar with the skin thickness and consistency of various sites to perform venous access proficiently. The skin is an important organ of the body. The skin's functions are for protection, regulation of temperature. It has a role in metabolism, sensation, synthesis of vitamin D, and communication. The two main layers of the skin are the epidermis and the dermis. Both overlie the subcutaneous tissue, which is also known as the hypodermis. The epidermis is the first layer of defense against infection. It contains squamous cells that are less sensitive than underlying structures. It is thin and contains no vascularity. It is also known as avascular. It regenerates about every 28 days. It is important to keep this in mind that this layer also contains normal flora for protection. The dermis is a layer of skin containing blood vessels, hair follicles, sweat glands, sebaceous glands, and nerve endings. The extensive network of nerves in this layer causes the patient to feel pain during the venipuncture. Sensory receptors are important in understanding infusion therapy and venipuncture. There are mechanoreceptors, which provide tactile sensations. These receptors provide information related to palpation of veins, placement of dressings, tape, and removal. Thermoreceptors provide the temperature sensation, such as hot or cold. Nociceptors provide the pain sensation, such as that pain that is related to venipuncture. And chemoreceptors process osmotic pressure changes in the blood and decreased arterial pressure. The venous system consists of arteries and veins that distribute the blood to the capillaries and return the blood to the heart. There are layers within those vessels: the tunica adventitia, the tunica media, and the tunica intima. There are various locations in which we will start IVs: digital, metacarpal, cephalic, basilic, accessory cephalic, upper cephalic, median antebrachial, median basilic, median cubital, and antecubital. Prior to cannulating the vein, or what is called precannulation, we must do several things. First, we must check the physician's order. Secondly, we must be mindful of infection control practices, and hand washing is priority. We must make sure that all of our equipment is prepared. We need to do a patient assessment and prep the patient psychologically for the intervention, which is the intravenous stick. We must also select our site and have appropriate vein dilation so that we can be successful in our cannulation of the vein. Cannulation is when we actually start the IV. We need to be mindful of the needle selection. The appropriate size is the most important decision. We need to make sure, again, that we're mindful of infection control and are wearing gloves. We need to prepare the site per policy. There needs to be a vein entry, whether it's direct or indirect. And then we need to be mindful of catheter stabilization and dressing management. From the post-cannulation standpoint, we must label the information about the IV in and of itself. We must dispose of equipment appropriately into the appropriate sharps containers if necessary. Patient education is key. We must calculate our rates for the IV infusion, and we must document all of this in the patient's nursing notes. This is the end of Module 5.